Hi, everyone. My name is Dr. Allison O'Neill. I am a pediatric oncologist that practices at Dana-Farber Cancer Institute and Boston Children's Hospital. We're a joint center for cancer and blood disorders, and we have an embedded liver tumor center of excellence wherein we treat a myriad of patients with primary liver tumors. Those include the most common of liver tumors occurring in pediatric patients, but also the uncommon. And the reason I'm here today is that we see a broad practice of patients with fibrolamellar hepatocellular carcinoma and have amassed a very comprehensive and multidisciplinary team intended to treat these patients. Part of what I'm here to discuss today is the fact that our team recently came together to publish a review article or manuscript entitled Fibrolamellar Carcinoma, quote, an entity all its own. The reason we came together to do this is A, we feel it absolutely crucial to communicate to the community of providers, patients, families, et cetera, that this disease must be treated in a multidisciplinary way. The authors of this manuscript were members of our Liver Tumor Center of Excellence and our multidisciplinary team, with representatives from oncology, radiology, surgery, pathology, our genomics team, our interventional radiology team, and our surgical team. And in truth, it was very easy for us to come together for this initiative because this is how we think about each and every one of our patients. We meet in a multidisciplinary setting. We discuss these patients from multiple different aspects and from different viewpoints and through different lenses from the standpoint of expertise. And so in writing this manuscript, we self-tasked our group to reference the most available and up-to-date literature surrounding the care of fibrolamellar hepatocellular carcinoma patients. Part of the reason this is so important to us is, as many of you know, providers in the community, providers at large academic centers, patients, families alike, there is very little evidence driving our current management of patients with fibrolamellar HCC or fibrolamellar carcinoma. Part of the reason for this is that when studies are published, they're often small studies, very few numbers of patients. So it becomes difficult to derive the right path forward to conclude which treatments make the most sense and which should be pursued by providers and teams alike. I think this can be confusing for patients and families and also for providers. And so our goal was to distill down the published information to the best of our ability. We sourced data from peer-reviewed journals, which, as you may or may not know, are the most rigorously reviewed publications available. And we did so with a fine-tooth comb, with the prospect of really distilling down the information and the data in easy-to-explain terms and to communicate the most robust conclusions from this data. We review in this manuscript an introduction with regards to disease, presentation, the demographics of patients often infected, the symptoms with which patients present, and some of the blood work or laboratory work that is most consistently checked for patients with a new diagnosis. We then delve into the pathology of the disease. What does the disease look like under the microscope? What are the characteristic features of the cells, the stains that are utilized by pathologists to identify this disease? We have a series of figures within the manuscript that can allow a pathologist to look at this data in granularity and to compare what they're seeing under the microscope with pictures of the tumor that are specific to the tumor as a guideline. We subsequently delve into the biology of the tumor. This includes the characteristic fusion transcript seen in all cases, the DNA JB1 PRKACA fusion, which many of you may be familiar with. And we have a very simplified figure that allows folks to understand the implications of this fusion and what we're looking for when we test for this fusion. We reference ongoing work in the preclinical space or in the research world, but at a high level, such that individuals reading can get a sense as to current work that is ongoing. Finally, we turn to what's called local control. When we think about patients with fibrolamellar carcinoma, we know the importance of surgery, but the realities are not all surgery is good surgery. Not all aggressive surgery is the right surgery. And so what we intended to do was really delve into the data. What data is available for aggressive surgeries? What data is available for transplant or conventional surgeries? And we go through topic by topic, the available literature that is published that is linked to improved survival. And you'll notice in looking for the manuscript that this data is limited. So when we conclude as a community that aggressive surgery equates to better outcomes, there is not data currently published to 100% agree with that conclusion. And so as a group, we self-tasked, particularly our surgeons, to go through that literature and identify whether there is discrete data to prove this premise. We also look through data on radiotherapy. Radiotherapy is commonly utilized in fibrolamellar carcinoma, and the question is it efficacious? The little literature that is published suggests it is, but again, there are a few case series and there's minimal data in that regard. We likewise broach interventional radiology techniques. These include direct delivery of chemotherapy, radiation, etc. These procedures have been shown to be efficacious, but again, in small patient cohorts, difficult to derive conclusions. That's not to say they aren't helpful for some patients, but we haven't been able to study them in a large number of patients to know whether they're helpful in the long term. And finally, we spend the most time on systemic therapies. There's one table within the manuscript termed Table 1. That lists every publication to date and the number of patients studied for each quote unquote systemic therapy. Systemic therapies come in one of three categorizations: conventional chemotherapeutics, targeted agents, or immunotherapeutics for the most part. We try to distill down the literature into one of these three broad topics and include the granular data from each of the publications. The one thing I want to emphasize here is that many studies have very small patient numbers, and other studies only report on time to progression without providing granular detail about the burden of disease present at the time the medication or therapy is started. When you have vague data like that, it becomes difficult to conclude whether the therapy is solely responsible for the progression-free survival or the extended period without disease growth. Our goal here was to really tease through the data, and in the end, it becomes very difficult to conclude which therapies are discretely linked to improvements in overall survival. And our conclusion here is that it is so important for the fibrolamellar research community to come together and to study drugs and therapies prospectively. Prospective research studies are so important. Patients are enrolled and followed from the time of enrollment through surgery and every treatment time point. That allows us to better trust the data, understand how the patient is responding and to what, and believe the published outcomes once they are in fact made public. I think with the data we have available now, either data was reported in retrospect, i.e. after the patients had already been treated, which can lend open to bias, or small enough patient numbers with incomplete data were published, which makes it difficult again for us to reach conclusions. So as a group, we remain very interested as always in collaborating with as many providers as possible to move forward this field in a meaningful way and in a prospective fashion, such that we can trust the data on systemic therapies in a more meaningful way. I think the last thing we really focus on is where to go from here. What other promising therapies are coming down the road, how we can think about engaging our lab-based investigators or our translational investigators to work with us as clinicians such that we can identify novel therapies and either study them on their own or study them in conjunction with the few therapies we know have yielded some promise to this point. That's really where the field is moving, and we hope as a collaborative community we can facilitate those goals.